moving on to the next topic, I invite senior spine surgeon Mohinder Kaushal. He will be speaking on Distando endospine system and his experience. Over to Dr. Mohinder, sir. So we'll invite our international speaker, Professor Oscar Alves from Portuguese. So Portugal. So he will be speaking on MIS posterior cervical fusion. So welcome, Professor Oscar. So you can start your presentation.
Morning from Portugal. Thank you so much for your kind invitation to NSSA. My topic is minimally invasive posterior cervical fusion, and I have no disclosures relevant for this presentation. As you know, open posterior laminectomy and fusion has benefits because it avoids the anterior exposure risks. You can access to multiple levels. That's the way you can achieve the widest canal decompression and high fusion rates. But there are quite important drawbacks. You have iatrogenic morbidity from muscle denervation, ligament section, long operative time, increased blood loss, longer length of stay, 60.3% 30-day readmission rate, high infection rate. Around 1/3 of the patients have moderate to severe postoperative pain. The surgical alignment, there are equivocal results in the literature, and you can have screw-related complications. The MIS posterior facet joint fusion shares all the benefits of the MIS. It's a tissue-sparing technique, direct access to the facet joint, no blood loss at all, improved operative time, shortened hospital stay, less postoperative pain, reduction of infection, and fast recovery. On the contrary, some handicaps related with indirect visualization, so you need to be very focused on radiology and carries the risk of radiation exposure. If you look at with this technique, the muscle damage, it was really minimized in all muscles of the cervical spine. And this will lead to reduced muscle atrophy, means less pain and less long-term kyphosis. The length of stay, if you use it on different indications, it's slightly around 1 day. And doesn't matter how many levels you treat. This is the OR setup, prone position, the neck in neutral position, and this is the kind of landmarks that you put on the skin, the midline, the medial line of the facet joint and lateral border of the facet joint. And you go from medial to lateral technique. This will guide you away from the canal, and you go upwards according to the facet joint orientation. The vertebral artery, as you see here, is protected by the pedicle. And if you keep in a line posterior to the vertebral body wall, you never reach the vertebral artery. And as you see here, the nerve root exits in the bottom of the foramen, contrary to the lumbar spine. What about the biomechanical stability compared with lateral mass screws? You can afford comparable segmental instability. If you supplement ACDF with posterior cages, you have a much better construct if you want to do a 360 fusion. Significant improvement of pain comparable to traditional procedures. And what's very interesting are the fusion rates. Evidence of bridging tubercular bone at 24 months, 2 years of 98%, and no translation motion at all in all patients. And why is that? Because the facet surface area that you see here is comparable to interbody surface area if you do an ACDF. Also, you have a much shorter distance for bridging bone. The facet articular height is less also than the disc height, and generally this facet joint bone, the facet bone is better quality than the vertebral body bone. Regarding sagittal balance, there is no evidence of significant loss of cervical lordosis. As you see here, it's almost more or less at 12 months. Overall lordosis, it's around 0. And this is due to the fact that the parallel shape of the device. And if you compare this with interspinous process devices, why you don't have so much kyphotic effect? Because the facets are closely behind the center of rotation. So the applied moment arm for cervical facet destruction is much less, negligible almost when compared with interspinous process devices. Very low rate of complications, 3.4%, and 17% of exit segment degeneration, but no need for reoperation compared with other anterior or posterior traditional techniques. What are the indications? Whenever you have a non-fusion, which is symptomatic, adjacent level disease, or a failed total disc replacement, if you want to avoid reopen again from the front, you can use this posterior facet transfusion. Or if you want to do a quick 360 fusion, or when you do your laminectomy, you want to supplement with fusion, or a very common application for indirect foraminal decompression and fusion. These are cases of symptomatic pseudoarthrosis with surrogate endpoints for outcome much less than we do in a CDF or a posterior approach, with hospital stay of 1 day, minimal blood loss, operative time, very quick surgery, with 100% fusion and positive clinical outcome. This is an example here of a pseudoarthrosis solved with this technique. Again, another case, a failed cervical arthroplasty here. As you see, a lot of motion, and there was successful operation, ADR for resolution of arm pain, but 9 months postoperatively, he had a range of motion of 19 with the prosthesis, and I had to do this kind of surgery. And 18 months post-op, he was asymptomatic with evidence of good fusion. Isolated foraminal stenosis, it's a really good indication for this technique. The alternative technique is posterior foraminotomy that has a reoperation rate of around 10%, but it's follow-up dependent. The more you follow the patient, the more reoperation you have. At 10 years follow-up, the reoperation rate for a posterior foraminotomy can be almost 25%. When you do a posterior foraminotomy, there are limitations. The degree of decompression is limited to the amount of bone that can be removed safely, which means always less than 50%. Bilateral decompression puts higher risk of instability. And with foraminotomy, you don't achieve fusion, which is part of the problem, because motion can cause you persistent facial facet pain. And as you know, axial neck pain is a contraindication for posterior foraminotomy. These are cases of isolated foraminal stenosis that were solved with this device. Again, here three-level, you see three-level devices were implanted with a really small incision. Through the small incision, I could approach the 3 levels. And this is the postoperative scans and X-ray. So there is a rapid symptom improvement on VAS and NDI. In conclusion, this is a technique with very low morbidity. It's a tissue sparing technique, avoiding many of the approach-related complications with open posterior or ACDF. It provides indirect and bilateral foraminal decompression with excellent clinical outcomes. It stabilizes as well as ACDF or lateral mass screws, reducing significantly the range of motion. High fusion rates are important to solve the long-term radiculopathy. And it's cost-effective, disposable, quick operation, day surgery, less post-operative pain, and a very short learning curve. Of course, it does not address the spinal cord compression, although the canal may expand dimensions by reducing the buckling of PLL and ligamental flabber. Major instability is contraindicated, and as I show you, it does not cause major kyphosis, but does not reduce it as well. Thank you. And I invite you to join us in Paris for our CSRS Europe meeting, or at least you can follow it also online. Thank you so much.
Thank you, Professor Alves. So it was a wonderful talk. So I have two questions for you. How do you decide and what parameters you make you decide the size of the implant? How do you decide what size of the implant you need to place?
Yeah, Dr. Shura. Yeah, I mean, this implant is 4 millimeters high. There are no other sizes. It's a single size.
Okay.
So what you do, you increase the height of the foramen, it's an indirect decompression, like you do in ACDS.
Yeah. So
Okay.
the maximum height. Yeah.
Only when you do a foraminotomy, you can increase anteroposterior dimension of the foramen. But here, you increase height, as in ACDS. It's the same principle.
Okay. So maximum the size of the cage, the implant is 4 millimeter.
Yes. Yeah.
Okay. So, and the second question, what are your experience regarding the implant failure? Any time the implant has backed out, or in your experience, chance of implant back out when you put a implant, so patient and follow up, so implant comes out. You have any experience with that?
No, not at all. I mean, the primary stability is quite good. It's very good. If you want to try to pull it back once you insert it, it's almost impossible. So we have not cases of pull out of the implant so far. But as you expect, pull out would be posterior, so it will be very easy to take it out in case of this comes out. I guess lateral migration would not be a problem, or anterior migration, you have the pedicle, so it's not really a question.
Thank you. It was a wonderful presentation, and
Thank
good
you.
to
My
have you
pleasure.
at NSSA.
Yeah.
Thank you.
So
Thank
much.
you. Thank you very much.